So it's a pleasure to be here because I am one a little bit different from others, and Hamid knows that because I am a new adopter. I've been correcting adult deformity with other techniques like A-lif and X-lif, and now I have like experience with that kind of techniques, and now I'm gaining new experience with the Ollif and the benefits of doing a faster, safer, and getting almost or the same results as in the recent past. So yeah, my talk after that introduction is about deformity correction. I won't go over the technique because really the you have talked about a lot about that, but yeah, I want to talk about what benefits I see in terms of deformity correction and what we can do with the Ollif technique and segmental correction. So as an introduction, there is a lot of literature talking about the anatomics of the Kambin triangle. You are all experts on that space, but I love to see that picture that I have in the slide, and then I highlight the size, the mean size of the base of the triangle in cadaveric studies, and it's not a small space at all. And mostly in L4, L5, L5S1, we can manage to use this approach to insert a cage, an arrow cage, the same size or sizes, big sizes, like we want to achieve not only correction, then again indirect decompression that I really a believer in the indirect decompression. Then I will focus on, of course, in adult deformity because the objectives and symptoms aren't the same, and we all know that. I really believe that we have to combine. I heard that I'm totally agreed that we don't operate on X-rays, but we can't forget about sagittal balance and the importance of sagittal balance in adults or even in adolescents, but in adults I think it's key. And differentiate between segmental correction and global correction, and if you need to go to pelvis or not. And again, sagittal balance for me is important, and I really now believe that I can do the correction of sagittal balance with Ollif technique as well as when I did in the past A-lifts and X-lifts. So a fast slide. I always ask for long cassette X-rays for all my patients, even if it's one level spondylolisthesis. And well, I always encourage my residents to learn about sagittal balance, all the angles that are published. It's very an abstract concept, but there is always a way to understand and know what is pelvic incidence and know what is lordosis. So in countries like Ecuador, you don't always have the resource for a long cassette X-ray. So I ask patients, and I encourage my residents to ask for maybe a lumbar X-ray with including the hips, where you can assess a little bit more exact the spinopelvic alignment. So why you can ask yourself why Dr. Nicola is trying to or bringing this presentation, and why he's moving, because really I've been doing well with A-lifts and X-lift, but our techniques that when you talk about complications and time of doing this, it's a little bit different what I see with my short experience with Ollif with Dr. Havasi. So like you see, there's many articles talking about complication in surgical intervention for autoscoliosis. You see the high rates of complication. You have to look for this patient maybe are high morbidity patients, senescence, frailty, and bone quality is very important to take care in this kind of patient. There is another publication that I like to highlight because it separates the complication between the diagnosis, neuromuscular scoliosis, adult scoliosis, or idiopathic. You see that the higher rate of complication always is adult scoliosis. Another article talking about this topic and highlighting the pseudoarthrosis, the high pseudoarthrosis in that kind of case of posterior posterolateral only cases. And this is a high multi-center study that I love, and I learned a lot with this presentation. And they talk about perioperative and delayed complication, and look at the high level of revision surgery required after a posterior only surgery in adult. And that's one thing that make us think what to do to improve that. So let's talk about what is really indication for correction in degenerative scoliosis. Not of course, not all the curves are needed for surgery. Okay, if you don't have symptoms, of course, and the balance of the patient is not that bad, you don't need surgery. But once you need surgery, what are the options? I like to go over the Ollif and the misdelief, and this is the trajectory. And when you see an actual view, this is the spectrum of the disc that you can use to correct deformity with Ollif. Okay, you have almost all the disc from the point of view of the Kambin triangle. And when you see the coronal view, this is an example. What you can get, you can position the cage like everybody says that has more experience than me in the best position that you planned in the preoperative planning, and you can achieve a very good correction of the sagittal balance and the deformity itself. This is the sagittal view, an example of what you can do. You can position a big cage, enough big cage, and of course decompress and recalibrate the spine in a good way with the Ollif. And this is the one that I like more to show, because you can position the cage in the middle, in the front, or even in the back. We've done some cases in Quito, and that's one thing I liked about this technique, because Dr. Habasi, I told him we're going from the left side, and I'm worried because the compression is in the right side, and he told me we can go as right as you want. You can position and decompress directly, almost directly, in the other Trans Kambin, the other side Trans Kambin space, and it's like that. So this is an example where you can position. I won't go over that because you have more slides and more x-rays than me. Example patient. This is an example of a case done by Dr. Abbasi, and you can see how you can correct the coronal balance. This is another case. And this is important to see. The segmental correction. This is the concept that I like with Trans Kambin Ollif. And you can go over a scoliosis, and level by level you can get a segmental correction, and then achieve a fair correction for the patient. And maybe in some cases you don't need to go for a T10 pelvis surgery, as is like a pandemic thing that we are seeing in the present. This is another case example, a patient with a 4-level correction of his deformity. And then, well, this is the measures to take, always with minimal invasive, specifically with Ollif. You preserve the posterior elements and reduce the postoperative pain, and increase the recovery of the patient. You can do with Ollif a very good height restoration of the disc, even for correction of the deformity, and of course indirect decompression of the neural structures. and reduce approach morbidity because all related with minimal invasive surgery. Thank you very much.